So as we're looking at craniovertebral ligament stress tests in the current IFOMP guidelines, they've narrowed down some of the tests that are being performed. So what we're going to look at technically is traction and flexion, alar ligament stress tests, and then we'll check on some of the transverse ligament tests just to be safe. So when we start out, we want to get our hands, and when you find the mastoid process, you'll get under the suboccipitals, just like a suboccipital release. And then I'll have you straighten your legs. Why I do this is that I want you to try that and see how much tension goes through your hands. And what you'll realize is there's more tension going through the system with the legs straight. So when you do your craniovertebral ligament stress test, I would like the knees bent. From this position here, you can also do traction. Now, you would have felt that traction when he straightened his legs, but you can also just lean back and hold. You're looking for any reproduction of symptoms. You're looking to see if this causes nystagmus, retroocular eye pain, anything like that that would make you concerned on manipulating this joint. If we're doing traction and flexion, what we can do is we can set up our hand under the occiput, and then the other hand is at C2. I can set my arm up so that I'm on the top of the forehead, and then I can lean back and do traction and neutral, looking at the eyes, seeing if that reproduces symptoms. And then I can do craniovertebral flexion by bringing the head into flexion, fixing C2, and producing a traction motion. In addition, you can get under C1 and lift. Now, if I'm moving C1 anterior on C2, that is the difference between the dens and the transverse ligament. So you're lifting C1 on C2, making sure they're moving together, and you're not getting any signs and symptoms into the lower extremities or the arms. That's a rare one. I would say that's a zebra, but you can do that one in order to keep yourself safe. Last is the alar ligament, which is the most common one. In this case, what we're going to do is do a grip like this onto C2. When we fix C2, we remember the alar ligament goes from the base of the dens at C2 up to the occiput. So when I side bend him to the right, and the axis is through the nose, and I'm fixing on the side of C2, there should be no motion or no reproduction of pain. Now, because there's a variation in the alar ligament, we also do it with some CV flexion and some CV extension, holding it in order to see if there's reproduction of pain or motion. What I would do if I were you is not hold it and do the side bending and feel the spinous process go into your thumb. That alone is a test they use to see if the alar ligament's intact. Then what we do is you just put enough pressure to stop that, and you check it in the 3 directions. Then you switch hands. Now my right hand is here. I'm giving a low compression through the head. I'm right on C2, so I'll start at C3, take up some of the slack to C2, and side bend to the left, which would be testing the right alar ligament, checking it in flexion and extension. And again, if I didn't put any pressure through, I would feel the spinous process come into my thumb. And now if I add a little compression and side bending, that will either provoke pain or reproduce motion.